Dear friends, colleagues, and students, a very good morning. On behalf of the panelists, I would like to thank everyone for making the time to attend this webinar. This webinar is organized by Alice Lee Center for Nursing Studies, National University of Singapore. I'm Wenru, Associate Professor from NUS Nursing. I'm the moderator for this webinar. First of all, I would like to invite Prof. Emily Ong, the head of department, to make an opening speech. Prof. Emily, please.
Good morning, everyone. A very warm welcome to our inaugural webinar. I'm delighted to share that the response to this webinar has been very overwhelming. Thank you for your support. I'd like to introduce briefly our department to all the participants. Our department is known as the Alice Lee Center of Nursing Studies. It is within the Yong Loo Lin School of Medicine, National University of Singapore. NUS is Singapore's flagship university and a leading global university centered in Asia. We offer undergrad and postgrad programs and have a total population of over 1,000 students. Our research program covers the following: chronic illness and long-term care, women and child health care, patient safety and quality of care, geriatric care, and wellness. I hope that you can go to our website to learn more about our department and our research program, and we welcome all of you to collaborate with us in the future. Let me once again thank you for participating in this webinar, and I hope you have an enlightening one today.
Thank you, Prof. Emily, for your introduction to our education and research programs. Actually, to add on to Prof. Emily's introduction, our master and PhD programs are open to international students. So if you are interested in our programs, you can actually always visit our school website to find out more information. Okay? Now let's move to our today's session on the topic of biobehavioral links in heart failure self-care, Blink Heart. I will start by introducing our four speakers and also give a very brief overview of heart failure and its self-care. Throughout the session, you can actually ask your questions at any time with the Q&A function at the bottom of your screen. The panel will answer your questions at the end of the session. We're going to have about 15 to 20 minutes for Q&A at the end of the session, okay? So our today's session is about biobehavioral links heart failure self-care. Again, I'm Wenru, Associate Professor from Alice Lee Center for Nursing Studies, NUS. So yeah, let me introduce our four speakers. Our first speaker, Dr. Catherine Dong. Dr. Catherine is a research assistant professor of NUS Nursing, and her research interest is actually in neurocognitive assessment instrument, heart and brain connection, and vascular cognitive impairment and brain training. Our second speaker, Dr. Jocelyn Chew. Jocelyn is our new research fellow, and her research interest is in cardiac metabolic disease self-management, biobehavioral mechanisms of self-regulation, and the usage of technology for health behavior change. Okay, yeah, our second speaker, Dr. Jiang Ying. Dr. Jiang Ying is also our research fellow, and her research interests lie in the area of cardiovascular nursing and cardiac rehabilitation, chronic disease management, and mental health. Our last but not least, okay, our Miss Juvena. Juvena is our cardiac APN from National University Hospital, and her area of interest include critical care and heart failure management. Okay, so they will actually share with us about their research projects and also their clinical experience in taking care of patients with heart failure. Now, I just would like to have a brief introduction of the heart failure and also its self-care. Talking about heart failure, I think, it's not unfamiliar for us. Heart failure is a chronic progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs for blood and oxygen. So the patients actually may experience various signs and symptoms. For example, short of breath, swollen feet, and also fatigue. Okay. Common causes of heart failure include coronary artery disease, hypertension, artery fibrillation, vascular heart disease, and also diabetes. Living with heart failure can be challenged as it actually frequently occurs at the clinical endpoint of many cardiovascular diseases. With the aging population, heart failure actually is a major public health problem with an estimated global prevalence of 38 million worldwide. In Europe, actually, there are at least 15 million people living with heart failure, and the prevalence of heart failure is up between 2 to 3%. In the United States, heart failure had also an estimated prevalence of 5.7 million, and also with nearly 1 million new cases actually diagnosed every year. In Southeast Asia, about 9 million of people also suffer from heart failure. So heart failure is actually is becoming a greater concern of the population. And actually, there was one study published in 2015. If you look at the prevalence in Southeast Asia, especially in Singapore and Malaysia, so the prevalence in Singapore and Malaysia actually are much higher when compared with other countries like, North America and also even China, So this may be because, in Singapore, the common causes which include hypertension, diabetes, and also coronary heart disease. These actually causes are more common actually among Singaporeans. Studies has found that the prevalence of diabetes is much higher in Singaporean compared with the Western population. And also, it was found that the Singaporeans actually face heart failure 10 years before Westerns. So it's actually a big health issue in Singapore, heart failure. So the impact of heart failure not only actually impact the physical functions of the patients, but also their psychosocial well-being. So heart failure actually negatively affects patients' quality of life, their psychosocial well-being, and also economic capacity. And studies has found that anxiety and depression actually were very common among patients with heart failure. In addition, heart failure is also one of the most common causes of hospital admissions and readmissions, representing a major driver for healthcare expenditure. So in Singapore, actually heart failure accounting for about 17% of all cardiac admission, and heart failure readmission risk is also about 18%, with an average length of stay of 5.2 days per admission. But sometimes this, length of hospitalization can be very short. Some patients, they may actually just admitted at the hospital for 1 or 2 days, and then they can be discharged. And also, the study has found that about 40% of heart failure patients would be readmitted to the hospital because of the heart failure-related conditions within 6 months after hospital discharge. So, common aims for heart failure management include actually reduce morbidity, reduce their symptoms and hospital admission. Of course, need to improve patient function status, improve their quality of life, and also slow down their disease progression, improve their survival. The management of the heart failure basically categorized into two categories. The first is actually the medical management, which includes pharmacotherapy, surgical interventions, or device therapy. Another management will be patient self-management. Patient self-management actually plays a very, very important role in their daily life. Self-management actually refers to multifaceted disease management interventions that actually promote self-care in patients with heart failure by ensuring patients to have adequate knowledge, skills, and engagement to carry out their self-care activities. In fact, actually, not only the biological factors, but also psychosocial and behavioral factors play the role in patient self-care. So today, we will have 4 speakers, Dr. Catherine, Dr. Jocelyn, and Dr. Jiang Ying, as well as Ms. Juvena. They will share with us about their research studies and also their clinical experience in taking care of patients with heart failure. Dr. Catherine will share about her study on the cognitive impairment and heart failure. Dr. Jocelyn will actually share her study on improving heart failure self-care using a neurobiological informed model. Dr. Jiang Ying is going to share her study on a nurse-led home-based psychosocial approach to enhance self-care for patients with heart failure. Finally, Ms. Juvena will share her role as a APN in the management of heart failure. Okay, now I would like to invite our first speaker, Dr. Catherine, to share with us about her research project. Over to you, Dr. Catherine.
Okay, thank you very much, Wenru. Good morning, everyone. Welcome to the webinar. We are glad that you are interested in this webinar and here to share with you about our studies in cognitive impairment in Asian patients with heart failure. So as Wenru has shared just now, that heart failure patients, they have complex self-care needs, and also a lot of them, they do have like high readmission rate, and a lot to do with their poor management of their health. So we want to know from neurocognitive perspective, is that true that heart failure patients, do they actually have poor ability in terms of their cognitive ability in managing their self-care? So that's why we do this study, and because we know from previous study that heart failure patients have twice the risk of developing cognitive impairment relative to age-matched controls, with a prevalence in Western population ranging from 25% to 85%. So this is pretty high. And cognitive impairment in heart failure patients lead to poor medication adherence and self-care. And because a lot of times they have multiple medication, they have a complex medication regime. They may have like 5, 6, medication they have to adhere to, and a lot of times they also have a complex instructions. For example, in terms of their daily weight and weighing themselves, as well as fluid intake output, they have to monitor. So these are things that they have to watch over. So with that kind of self-care needs, it's important to look at whether how is the scale of the problem in terms of cognitive impairment in Asian patients with heart failure. And also we want to look at the clinical and biomarker correlates of cognitive impairment in heart failure, because this is not known. So there are some proposed mechanisms of cognitive impairment in heart failure. For example, cardiac inefficiency. So there's decreased cerebral blood perfusion resulting in microvascular changes in the brain, and also cerebral emboli and silent stroke. And development of heart failure or worsening heart failure severity may be associated with decline in cognition. Additionally, cardiac biomarker like NT-proBNP, CT&T were associated with cognitive impairment in the presence of cerebral vascular disease. This has been reported before. However, the link between the heart and the brain, that means cardiac and cognitive function, is not established. Therefore, we aim to establish the prevalence and clinical correlates of cognitive impairment in Asian patients with heart failure. So we actually did a study looking at, from this aspect, prevalence, biomarker, and clinical correlates and outcome in terms of cognitive impairment in Asian patients' heart failure. We did this with 100 heart failure patients in Singapore by giving them brief cognitive tests, like the commonly used mini-mental state examination, Montreal cognitive assessment, as well as comprehensive neuropsychological assessment to diagnose their cognitive impairment. So we also collected data on clinical characteristic, blood biomarker, and their functional data with 1 year follow-up of these 100 patients. So what we found that obviously is expected that they have, age definitely make a difference for patients with cognitive impairment. So they are older, in their 60s, while the ones without cognitive impairment in their 50s. And though, of course, we know education make a difference for cognitive function. Those with cognitive impairment, their education level is slightly is lower than those without cognitive impairment. And of course, brief cognitive tests like MSc, MOCA do those with cognitive impairment do perform do have a lower value. That means they have poor performance compared to those with no cognitive impairment. And we also note that their cardiovascular total number of cardiovascular risk factors, that means the number of their diabetes, hypertension, coronary artery disease, atrial fibrillation, smoking, prior stroke, and current chronic kidney disease. All these actually, those with cognitive impairment, they do have higher risk. They have more risk factors in this area. So what we found is that it's quite alarming that 44% of patients have undiagnosed cognitive impairment with neuropsychological impairment characteristic of vascular pathology. So what does that mean? So these patients actually have, they are slow in processing information. They also have difficulty in terms of their executive function and their ability in visual spatial ability. So these are more in line with vascular pathology, which is like patients with a stroke and other vascular pathology. And so we note that 14% of heart failure patient has a documented history of stroke. While age is a strong predictor of cognitive impairment in heart failure patients, older patients more than 63-year-old had 6 times greater risk of having cognitive impairment per additional year. So we know that age and documented history of stroke do contribute to cognitive impairment. So what we did is we exclude these two factors by doing structured equation modeling. Well, the analysis showed that NT-proBNP was independently associated with cognitive impairment, hospitalization, and quality of life. So the optimal cutoff point we derive in this study is less than 28 for MSc and less than 25 for MOCA. And with acceptable sensitivity and specificity, and classification accuracy is quite good too. So these cutoff points are different from the conventional cutoff points from MOCA and MSc, and they are consistent with the previous study in heart failure patients. So heart failure patients without prior stroke, more than 63-year-old, with MSc score less than 28 or MOCA score less than 25 or high NT-proBNP may warrant a formal evaluation for cognitive impairment. So in relation to the heart-brain connection in aging and cognitive decline, there's a review in Nature Review Cardiology where they presented that since middle age, there will be systemic subclinical arteriosclerosis or arteriosclerosis that can contribute to heart disease or go directly to brain lesion. So if the pathway is go through heart disease, this patient may have like coronary heart disease, atrial fibrillation, or heart failure, and that can result in cerebral hypoperfusion, hypoxia, emboli. While if the pathway and then go to brain lesion, that is a stroke and other brain injury. While if there's a pathway from directly to the brain lesion, from subclinical arteriosclerosis directly to the brain lesion, then the patient may have stroke and a brain injury. And both will lead to cognitive decline, MCI, or dementia in the older age. So this is the postulation of the mechanism. We're also aware of the recent development in terms of non-pharmacological intervention for cognitive impairment, and that have been shown that it's been useful. For example, the quite well-known finger study that look at, older adults and in terms of the multi-domain lifestyle, intervention as well as cognitive training. So we did a review to look specifically in the population heart failure, looking at whether computerized cognitive training can improve cognition in patients with heart failure. in this review, we found that the studies in the area is quite limited, with 4 randomized control trials only. There's a preliminary evidence for the feasibility and efficacy of computerized cognitive training to enhance the processing speed, working memory, adaptive physical functioning. However, larger RCT studies are required to examine the efficacy of targeted cognitive training on uptake of self-care skill. In view of all that, we actually developed novel neurocognitive study on heart and brain connection, which we have been supported by Singapore National Medical Research Council Transition Award, which is funded for clinician scientists. So what we are doing is we actually have deep phenotyping of cognition and neuroimaging by doing formal neuropsychological assessment as well as brain scan, brain MRI, together with existing cardiac phenotyping, for example, cardiac echo, blood cardiac biomarkers, to examine the underlying mechanism contributing to cognitive impairment in heart failure patients. Additionally, we will also have longitudinal follow-up to establish predictors for cognitive decline in this population. And we are also developing this RCT intervention study on cognitive training to improve cognition and disease self-management, such as complex medication management in this population. So in terms of the heart-brain connection, specifically for the intervention aspect, we are developing Train Your Brain Heart Failure, HF. So cognitive training intervention, this is customized for heart failure patients with mild cognitive impairment. And it is delivered in a group format, 6 weekly sessions with additional 2 sessions for review, focus on therapeutic lifestyle change to improve heart and brain health, with cognitive training for specific cognitive domains such as improving attention, memory, and executive function. That means their ability to plan and organize, and also the mood management, because we know mood also contribute to poorer cognitive performance. So this is based on our Clinical Innovation Award, Train Your Brain, where we actually did it with a memory clinic group of patients with mild cognitive impairment. We had 19 patients. More than 80% attended the full program. There's a significant improvement on global cognition, executive function, and also psychological well-being, such as stress reduction. And we have been acknowledged with a Clinical Innovation Award from Australasia Society for Study of Brain Impairment in June 2017. So to conclude, the prevalence of undiagnosed cognitive impairment in Asian heart failure patients is high, almost half, and it's very alarming. Currently, there is no clinical guideline for cognitive screening. Our findings suggest MMC less than 28 and MoCA less than 25 as optimal cutoff point. Heart failure patient without prior stroke, more than 63-year-old or has a high NT-proBNP value may warrant a formal evaluation for CI. There's mechanistic studies on heart-brain connection and cognitive training intervention are needed to customize intervention and improve self-care in a heart failure patient. So we'd like to acknowledge our funder, Singapore National Medical Research Council, for their funding support, our collaborators from Singapore National University Heart Centre, Singapore National Heart Centre, and our study participant research team. And interested collaborators, please take note of my email and write to me, and we welcome collaboration. Thank you for your attention.
Thank you, Catherine, for sharing your study. I guess in this webinar, there might be some master or PhD students. So I always receive questions from the nursing students and ask me, as a nurse researcher, whether we can do some basic science studies. I think now you'll find the answer from Catherine, okay? Maybe just a quick brief summary of her study. Based on Dr. Catherine's study, you can see the prevalence of undiagnosed CI, cognitive impairment, in Asian heart failure patients was very high, reached almost half. The high rate of undiagnosed CI is concerning for patients with heart failure, given their medication complexity and numerous lifestyle modification. So using the published conventional mini mental states exam, MSE, I think we all know about this scale, okay, cutoff point less than 24. I think from her study, we can see 74% of cognitively impaired patients would be undetected. Okay, so I think Dr. Catherine and her team actually have done a very good study, and their study showed that the optimal cutoff points of MMSE less than 28 and MOCA less than 25 should be used for Asian patients with heart failure. And based on this cutoff score, most heart failure patients will be identified with cognitive impairment. So I think there is an urgent need for nurses actually to assess the cognitive function of heart failure patients so that an individualized or tailored intervention can be provided to enhance patients' self-care ability. Okay, again, thank you, Catherine. Okay, now I would like to invite our second speaker, Dr. Jocelyn Chew. Jocelyn, over to you, please.
Thank you very much, Prof. Wang, for the introduction, and a very warm welcome and good morning to everyone. It's definitely my pleasure to be here to share a little bit about my study, which is on improving heart failure self-care using a neurobiologically informed model. So before I share about my study and share screen, let me just share a little bit about my own experience with self-care. So recently, I think some of our friends here would know that together with 2 other colleagues, we decided to embark on a challenge, which is to run 2.5 km for 25 days to raise awareness for mental health. So to keep ourselves motivated, we intended to send pictures of ourselves running every night to each other, and also use a sumptuous Japanese food as a reward for our efforts at the end of this challenge. However, 14 days into the challenge, I dropped out and stopped exercising despite all this motivation, intention, and goals that we have set for ourselves. So this is what is well established as the intention behavior gap, which is what led or guided the entire project that I've done. So like I mentioned, I'll be sharing about the improving heart failure self-care using a neurobiologically informed model. So similarly, patients with heart failure know the importance of performing self-care behaviors like sodium restriction, regular exercise, but performance of such behaviors are usually quite poor due to an intention behavior gap. And therefore, the whole aim of this project was to develop a health behavior change program that could improve heart failure self-care. And at the same time, this project also aimed to examine the current level of heart failure self-care non-adherence and also understand the heart failure self-care intention behavior link. So this study was conducted in 3 phases, but due to the time constraint, I'll only be focusing on the 3rd phase for this study. So in phase 1, I conducted literature reviews to find out more about the influencing factors of self-care and also the effectiveness of various interventions used to do so. And this is basically to identify the research gaps in explaining the poor adherence to heart failure self-care. And after concluding that we need a new theoretical framework, we examined this, to examine this topic, I found a new theoretical framework, which is called temporal self-regulation theory, and conducted another review on it to understand more about how I can use it in this study. Next, in phase 2, I wanted to understand more about heart failure self-care behavior change in this group of patients, which is heart failure patients, by using this temporal self-regulation theory. And therefore, I conducted a qualitative and quantitative study on the various factors such as motivation, time perspective, habits, and self-regulation, so on and so forth. And I will touch on that a little later. But because Singapore is a multi-ethnic society with approximately 76% of Chinese, where a lot of our elderly Chinese patients cannot speak English, I had to conduct another study to translate one of the instruments that I couldn't find a Chinese version for. Because for this study, I used both English and Chinese questionnaires to explore all the variables. And one questionnaire, and this questionnaire, I'll talk about how I did the translation a little later. And then in the 3rd phase, I used all this information that were gathered in phase 1 and 2 to develop a contextualized and localized self-regulation program, and then tested its effectiveness on improving heart failure self-care in our Singaporean patients with heart failure. So this is basically a very broad overview of what I've done. So this is a very simple diagram that shows you the temporal self-regulation theory, which, like any other behavior theory, such as the theory of planned behavior and theory of reasoned action, is very much based upon the intention behavior link. So you keep hearing me talk about this link throughout this entire presentation. But in this theory, It posits that this intention-behavior link is actually influenced by three factors, namely time perspective, behavior prepotency, and executive function, which is what Prof. Dong has actually mentioned just now. So very briefly, time perspective refers to the extent to which one thinks about the future consequences of their current behavior. Behavior prepotency is the automaticity of a certain behavior, something like habits. And executive function is a set of higher order cognitive processes needed for things like problem solving, reasoning, and logical thinking, so on and so forth. So for each of these factors, I actually used both English and Chinese versions of respective questionnaires because, like I mentioned, Singapore is a multi-ethnic society. However, I couldn't find a validated Chinese version of the consideration of future consequences scale, and so I had to translate it and validated it in a Singaporean population. So here's a very simple schematic representation of how I did the translation. I will not go through it in detail, but I'm sure you can tell that it was a very, very tedious process because I conducted at least 4 rounds of translation before I could even test out the psychometric properties in our heart failure patient. So if anyone is interested to find out more about this, I'll be very happy to share after this webinar. You can just contact me through email. I'll attach my email later at the end of this webinar. So next, based on the quantitative study in phase 2, we found that our heart failure self-care is indeed poor as compared to the mean non-adherence rates across 15 countries in the world. So Singapore is actually represented by the red bars and the global non-adherence rates are the blue. So comparing with our counterparts in countries with similar socio-economic profile like Taiwan and Hong Kong, our heart failure self-care non-adherence rates are slightly better but still below optimal because our self-care of heart failure index score is 51.2, which is way below the cutoff of 70. So to understand heart failure self-care behavior change even better, I conducted various analyses and found that time perspective, readiness to change, and behavior prepotency, which is how automatic a certain behavior is, were indeed significantly correlated with heart failure self-care, except for executive function. So executive function is basically made up of 3 components, namely mental flexibility, inhibition, and also working memory. So among all these 3 components, we only found a significant association between working memory and self-care, which makes a lot of sense because, you know, patients require a lot of memory to remember when to take their medication, what are reference values for the weight that they are supposed to maintain at, so on and so forth. And also through a mediation analysis, I found that there were indeed an indirect effect of readiness to change on heart failure self-care through time perspective, which means that an increase in readiness to change increases heart failure self-care only if there's an increase in time perspective. So if you're interested to find out more, you can also check out this paper that we have published from the results of this study. And then to understand the topic even deeper again, I conducted a qualitative study with 17 heart failure patients using unstructured interviews to understand the motivators, barriers, and self-regulation techniques that they use to improve heart failure self-care. So each interview lasted for around 42 minutes. Our participants were mostly males, Chinese, and the mean age was around 56 years old. So again, if you're interested to find out more, you can check out this paper that we've published. So through thematic analysis, 5 themes and 12 sub-themes emerged, and these were consistent with the temporal self-regulation theory. So for motivation, we realized that participants were more motivated because of the consideration of their family's future and their own past. So regarding the family's future, they wanted to prevent their family members from feeling worry and grief. And also, this is, the next point is very much applicable to patients who were younger, with younger children and a dependent spouse. So they actually felt a strong sense of responsibility to support their family. Next, they considered about their own past. They actually had a sense of regret that they didn't really look after their condition well enough in the past. So they wanted to right the wrongs and regain sense of normalcy. And then at the same time, a group of participants also talked about how a fatalistic consideration of their future actually demotivated them because they felt that, oh, we know that our heart failure survival rate, 5-year survival rate is 50%. And hence some of them actually perceived this as a very short residual lifespan and felt a little bit helpless, especially when a lot of them, even after adhering to medication, exercise and things like that, they still experience exacerbations. Some things we can't help. So that's for motivation. And then for challenges, we also found that there are two main challenges. Firstly is the challenge in deviating from personal dietary habits and social norms. So these are things like how, I myself cannot resist the temptation of my favorite snack if it's lying on the table. The convenience of eating out, especially when we are all very busy working adults. Dietary requests, sometimes if you request for less salt, the chef may actually come and question you and say, well, who are you to make me change the way I cook? So some hostility felt there. And also it is in our traditional cultural norm to finish up everything on our plate just to show that we respect the cook for cooking for us and how nice the dish is. So that's for personal dietary habits and social norms. And also integrating physical activity into daily routines was difficult, mainly because it's time consuming and boring. But this study was done before COVID. Now with COVID, it's possible that, with the flexible work timing, people are actually exercising more. And this is the next point is very important, fear of over-exertion. Some patients, they actually are wary of exercising too much and then exacerbate their heart failure condition. And then patients also talked about their self-regulation strategies used. So things like integrating physical activity into enjoyable activities, such as playing with their kids or jogging with their kids, things like that, self-monitoring, so on and so forth. With all these results, I developed the Push-Pull-Hold program, which lasted for 3 months with 1 face-to-face and 3 telephone follow-up sessions. So the reason for calling it Push-Pull-Hold is because in heart failure self-care, there are some health-risking behaviors such as overconsumption of salt that we need to reduce or pull back. So we call it pull. Some health promotion behaviors such as exercise or medication adherence that we need to push or increase, so push. And once the behavior change is achieved, we need to sustain and hold it there, so push-pull-hold program, a very, very simple term. So the whole idea of push-pull-hold program is actually to increase motivation to change. To do this, we actually enhanced future-oriented thinking and also to improve the translation from intention to behavior change through self-regulation training. So firstly, to increase motivations, participants attended individual face-to-face sessions that were conducted using motivational interviewing technique, targeted at evoking their motivations through guided considerations of their past regrets and future expectations. So we basically ask patients to think about a certain scenario in the past or the future and think about how it actually affects themselves or their families. And then the participants were guided in identifying the long and short-term benefits and risks of improving their self-care behaviors. Then they were to set 3 months goals and sign a contract with themselves so that they make this goal, this abstract goal, seem more concrete and commit to it. And then to enhance self-regulations, participants were provided with 3 components of this program. So first was verbal and print information and tips on heart failure self-care. So this is basically to reinforce the necessity of heart failure self-care. Second was a novel 2-step framework called the mindfulness-based interception D5. This is basically to initiate self-control. And third was a print booklet to facilitate self-monitoring. So basically, self-regulation means self-monitoring and self-control of your thoughts, behaviors, and emotions. So we had to include these 2 components, self-control and self-monitoring. So very briefly, MID5 is a 2-step framework that comprises of a mindfulness-based practice component and an if-then coping planning component. So mindfulness-based practice was used to firstly quieten down mental chatter for patients to use the if-then model to identify problematic cue response behaviors so that they can intercept them with some new responses that we actually provide the patients with, such as, so let's say if the patients normally at 4 p.m. will feel a bit peckish and they want to eat something, we could actually use a distraction technique or substitution technique, such as drinking more water before you eat that snack. So patients would feel full and maybe less likely to eat a snack, something like that. So they would then use the PPHP toolkit to make action plans repeatedly reminding themselves of their motivators, and perform daily monitoring and weekly reflections. So just want to slightly highlight the difference between action planning and coping planning. So in action planning, you actually plan a certain set of actions directly towards a goal. But for coping planning, you actually anticipate certain situational pitfalls and then come up with contingencies to cope with these potential pitfalls. So for example, if you anticipate overeating during Christmas or previously during Deepavali, then you may want to reduce your intake for lunch, let's say. So to test the effectiveness of this program, we conducted a randomized controlled trial at the National Heart Centre of Singapore with 144 participants. So these are some of the outcomes that we measured at baseline, week 12 and week 24. The mean age of our participants was 61 years old, mostly male. And at baseline, our results showed that time perspective, mindfulness, attention, intention, and behavior prepotency, which is mainly how automatic the behavior is, actually explain 56.8% of the variance in self-care of heart failure score. And then based on the generalized estimating equation model with intention to treat, our results showed that there was indeed a statistically significant improvement in the intervention compared to control group for self-care adherence, you can see, for both time 1 and time 2, meaning both week 12 and week 24. And then there was also a statistically significant improvement in future-oriented thinking and automaticity, but the effect for future-oriented thinking actually disappeared at time 2, which is a 6 months follow-up. So this suggests that although the effects of PPHP on self-care adherence was sustained 3 months after the intervention stopped, maybe because of increased automaticity of such self-care behaviors or constant practice and repetition, such that these behaviors become habits, that on time perspective was transient. So then there are some implications of these study results. Firstly, implications for clinical practice. We could actually use PPHP as a catalyst for behavior change, because just now we can see that there was actually a steep increase in the effects of PPHP on self-care adherence. And then it could also eventually be delivered in nurse-led heart failure clinic. And then implications for future research, we are actually in the midst of finding out which are the active ingredients of PPHP that led to an increase in self-care adherence. We also are thinking of finding out the sustainability of this project on behavior change. And some things that we could, all of us could actually explore is the possibility of earlier self-regulation interventions in preventing heart failure deterioration. So that's all for my presentation. So if you are interested in discussing more, I'll be very happy to discuss more. This is my email address. And thank you very much for listening.
Thank you, Jocelyn, for your sharing a wonderful study. I think for those PhD students, I think some of the PhD students may in this room, Jocelyn is actually sharing with us about a whole 4 years PhD study. Quality and plus interventional study is basically a mixed method. It's very complex, Yeah, so also a quick summary of her presentation. From her study, you can see actually heart failure self-care remains poor, especially in terms of their daily weighting, checking for ankle swelling, sodium restriction, and physical exercise. Stimulating future thinking improves actually patients' one's heart failure self-care. Then initial improvements in self-care have to be sustained by making them lifestyle habits. Coping strategies actually should be developed by patients themselves to be better integrated as a lifestyle habits. Okay, so patients should be empowered with self-regulation skills so that they can actually take ownership of their own self-care. So eventually, self-care is their own self-care. Okay, thank you, Jocelyn. Okay, now I would like to invite our third speaker, Dr. Jiang Ying. Okay, over to you, Jiang Ying, please.
Hello, hello, good morning, everyone, and friends and colleagues. I'm very happy today to share with you my study. Okay, so this is the title of the study. So it's the effectiveness of a nurse-led home-based heart failure self-management program for patients with chronic heart failure. So basically, the aim of the whole study project can be summarized in 2 aims. It's just to develop a nurse-led study intervention to improve patient self-management as well as to evaluate whether the intervention is effective or not. Method. So basically, we try to follow the UK Medical Research Council MLC framework from development to evaluate our intervention. So this MRC framework have emphasized the systematic and theory-driven development of the study intervention, conduct pilot testing, as well as use appropriate method to evaluate the study interventions. And then the last stage of the framework is the implementation and long-term surveillance and follow-up. So for our particular research project, we have basically complete the first development up until evaluation of the study intervention. So some of the findings from development and pilot testing have been published already previously. And for this webinar, I'm focused on the phase 3. So we want to show like how we evaluate the study intervention, whether the intervention is effective or not. So the study design, we have used a randomized control 3-arm between group repeat measures study design. We have recruited 213 patients from National University Hospital. So they were randomly allocated to one of the study groups. There are two experimental groups, experiment group A and experiment group B. So the difference is that in experiment group B, the participant will receive an additional mobile app, while experiment group A, they don't have a mobile application. And all these participants will be followed up from 6 weeks from baseline, which is immediate after the study intervention, up until 6 months from the baseline. As mentioned earlier, this is the multi-component intervention. It's a nurse-led and home-based. So the whole intervention duration is 6 weeks. And the nurse will visit patient every 2 weeks. So in total, there will be 3 home visits by the research nurse. In addition, participants in all the experimental groups, they will receive like self-management toolkits. So this toolkit will comprise a hard copy, heart failure educational manual, a drinking mug with marking indicate fluid intakes, a weight monitor calendars which have a graphical display of participants' weight trend, as well as you can see a medication box with compartments for daily consumption of medication. And another thing here is this is the alarm clock that allows participants to set multiple alarm reminders. So all this, the design of the toolkit is actually we want to use some of the simple, accessible items to help participants like to form to have a self-care like routine which can incorporate into their daily life routine. So we use an item is easily can purchase maybe from the shop. Yeah. And then the home visit by the research nurse, actually it covers a variety of activities. So the main purpose of the intervention is to improve self-care. So this will include to provide individualized education tailored to patients' need and readiness to change. And also we try to do some activity to facilitate patients transferring of self-care knowledge to actual practice. And also, along the way, we will evaluate whether patients, how is their understanding of the key concept of heart failure and heart failure self-care, and what are the self-care activity required for optimal heart failure care, as well as because we are working with the patient, our relationship is like collaboration relationship. So we set some goals for the patient to engage, to improve their engagement in this self-care activity. So some of for heart failure, the goals sometimes involved is really like improve quality of life while living with some of the illness conditions or disease burden, and improve functional status. Subsequent visits, the nurse will also monitor the patient's progress on nurse self-management, such as whether patient have followed our instruction, have medication compliance, how is the dietary management, whether they have any stress, emotional coping issues, things like that. And then when the family members are around, so we also provide sometimes on-site instruction and support to the participant and their family caregivers. So in a sense, to increase the partnership in the care. And most importantly, if they do something is right, we need to reinforce and encourage right behavior. We want to see more. And as you can see, a lot of components in our study intervention content. So we want to use some of the technique to link out all these components. So in this study, we use a motivational interviewing technique-based approach to deliver the study interventional content. So MI approach is a patient-centered collaborative communication style. It used to strengthen patients' own motivation and commitment to change. And the basic communication style follows OARs, open questioning, affirmation, reflection, and summaries. So actually research found that two components have been identified for leading an effective MI, which is the relational component and technical components. Actually, relational component is the clinical setting. Many clinicians use this component to build a rapport and set the stage for subsequent behavior change. And for technical components, we refer to like how we ask a question to really evoke or elicit patients' own motivation or reason for change and reinforce their commitment to change. The key process we follow also is engaging, focusing, evoking, and planning. So you may wonder how we have done and putting all these pieces together. So we have developed the structure guideline, a general structure guideline for each of the home visit. So for example, in home visit 1, probably patient and I may not know each other that well. So it's actually the stage of engaging. So we will ask open questions or chat with them. How are their understanding of heart failure condition as well? How is their understanding of heart failure cell care? So before we give a lot of information, we want to see what is their understanding and gaps. So from then on, we can fill in the gaps by providing by dispelling some of the confusion. And then subsequently, after warm up, we can set some of the agendas for heart failure cell care. So we can ask patients one by one, what do they want to change first? And these are the phases that we may need to use a bit of technique to evoke their own reasons for change. And sometimes also we have to negotiate some of the action plan with the patient. If everything goes well in session 2, that we will also we'll review patients' progress, and then we will move to like planning. Is like we foresee and break some of the maybe situation may be set into impact hinder patients to take care of certain cell care activity. So we have to brainstorm and plan out some of the possible solutions. In actual practice, we acknowledge that this is not a linear process. It really depends on patients' progress. And motivation interviewing sometimes it emphasizes a lot on why and why to change, but it's really a little bit on emphasized to do like how to do it. So in other clinical settings, for example, like substance use disorder, right, patient, if they resolve to changing, normally they are able to carry out certain action on their own. But it's not always the case in patients with heart failure, as mentioned by just now Dr. Kachin Tong. Sometimes patients, even they are willing to do some change, they still need some help to help them to like really carry out, to plan out some of the, rehearse some of the cell care activity and action. So in those cases, the home visit activity will still focus on like patient education and then skill building development, things like that. So our motivation interview is like form of like to try to build up and promote the engagement with the patients, so let them stay on to this process. So these are the pictures. You may see some of the action pictures when we go to home visit and talk to the patient and they document their weight in this calendar. Now I'm going to share with you the mobile app and web portal system. As mentioned earlier, participants in experiment group B, they receive additional mobile applications. So as you can see in the left-hand side, this is a mobile app. The end user will be the patients. So you can see we embed all the educational content in the mobile applications. In addition, there's another important function for the mobile app is the self-monitoring record functioning. So this is served like a digital diary for patients to jot down their weight, their blood pressures, the commonly used diuretic, as well as the symptom monitoring. The symptom monitoring will divide into mainly is like no symptom, baseline, that means there's no change of the baseline symptom and worsening of the symptom. These are the common symptoms that we list out in the app. So it's very important to patients to form a habit to use to check and record, because some of the heart failure symptoms may be very subtle. If patients do not have this like checking and recording, sometimes they will just miss out to interpret some of the symptoms. By checking in and recording, and then as you can see now, there is a daily view of all the symptoms. Patients can better interpret their health data. They can, together, they can interpret their subjective feeling, how overall generally they feel. They can look at their weight, whether they they have a weight increase, and then they can integrate other data like that, whether they have ankle edema as other symptoms. So in a sense that we also train patients to understand their body changes because of the heart failure condition. On the right-hand side is actually a web portal system. This is for the clinicians. So as you can see, when patient key in their weight, clinician in the back end, they can actually monitor patients' weight records. This is a display in a graphical display. So we see how is the trend of the weight after some time. Okay. So this is the study participants inclusion and exclusion criteria for our study. And this is the outcome measures. So as mentioned earlier, this study intervention, the aim is to improve cell care. So the primary outcome will be heart failure cell care. And we also have other secondary outcomes like self-efficacy, quality of life, psychological well-being, social support, functional status, and unplanned health service use related to cardiac conditions. So in more than a year's time, we screened actually 693 patients. But among them, we only able to, about 30% of them agree to participate in our study. So we recruit 213 patients. And among them, only 162 patients had complete all the study and complete all the post-follow-up study data collections. So the overall attrition rate is about 24%. So now you can see the demographic characteristic of our study sample for the 213 patients. So as you can see, that these patients belong to the older population. They are, the mean age is 68 years old, and most of them are Chinese. They are married, and a lot of them at the moment is not working or retired. So this is the clinical characteristic and baseline outcome variable. So what I want to highlight is that at baseline, our study sample actually they have inadequate cell care because the cutoff for adequate cell care for cell care of heart failure index is 70. So you can see the baseline score actually well below the cutoff of 70. Lastly, the FILO data analysis actually based on 162 participants who complete all the data collections. So for time being, I can't list out every single outcomes to share with you. So, but in general, the study, we have do an analysis, and we found that actually the intervention is largely confirm our hypothesis, and you can see either of the experiment group compared to control, they have significantly better in the following outcomes. However, the finding didn't confirm the effectiveness of intervention in improving patients' social support. And we found that both experiment group A and experiment group B are comparable in improved above outcome. And specifically, experiment group B compared to control, they show statistically significant in reduced use of unplanned health service use related to cardiac causes, while experiment A compared to control didn't show significant in this aspect. So then after the study intervention, so how does it relevant to our nursing practice? So we do a bit of reflection, so patient education. So nowadays, we may think patients have many information. They are more readily accessed to multiple health information. So we thought patients, they already be very well informed. But through the intervention, actually, this is not always the case. So we found that especially the old patient, they may not be so good to discern the vast amount of information, which leading them, resulting them to have incomplete or incorrect understanding of their condition. Even then, even when they have right information, they still need some people to like coach them to how to translate the knowledge to the actionable actions in terms of like really look after themselves and how to interpret those healthcare data. So the nurse still play a very important role in patient education, but now the education role maybe evolve a bit further. Instead of deliver information giving, but really have to identify gaps, dispel confusions, and then really have to provide personalized advices to the patient. And second is because like healthcare, cell care, and like other is really a behavior and lifestyle modification. So heart failure or other chronic disease management, they are unable to use a prescriptive or top-down manner to ask patients to just do something and follow us. So we really have to take into consideration of psychological and social aspect of some of the symptom presentation. And most of the time we use our relationship and try to influence patients to have like along the way to do more like a health desirable behavior change. And then this study actually is conducted before the COVID period. So we found that home visit still is a preferred way of engagement for many of the elderly patients, because they feel that compared to telephone call, they feel that when the nurse go down to their house, they are able to more clearly articulate themselves and talk about their concern, because they feel sometimes very hard for them to talk over the phone, and they feel that they are being rushed to end the conversations while they are talking to the phone. So home visit is their familiar environment, and they also feel that when the nurse go down and they can like see the house environment and things like that, so that the nurse in terms also can better understand them. And no doubt, lastly is the mHealth and technology components. No doubt it's very important, because we also believe that it's very important to have technology to overcome some of the common barrier for health access, like now, especially during this period of COVID pandemics, then we are having a webinar. But the role of mHealth and technology in the study, we found is more for a complement of our care and to supplement to nursing care. So what patients are saying is that they leave a mHealth technology, leave an app to them, and there is no access to our care. So this is their main worry. But if they see this is an additional access to link to the healthcare professional, actually they are willing to, the younger patient probably they are willing to embrace this change. So this is my last slide, and thank you for your attention, and my email is at the bottom of the slide. Thank you.
Thank you, Jiang Ying, for sharing a wonderful study. Yeah, actually to add on, this study actually is funded by Ministry of Health and MRC. So Jiang Ying actually, this is actually also her Jiang Ying's PhD study. And also just a quick summary of her presentation. As we can see, actually patient education still actually remain an important part in self-management intervention, especially for patients with chronic illness. And the multi-component psychosocial education approach is an effective way to improve overall self-care management in patients with heart failure. From this study, we can see actually home visit still remains preferred way of engagement for elderly patients. If you look at the mean age for Jiang Ying's study is about 68. And also you look at Dr. Jocelyn's study, the mean age also 61. So I think for patients with heart failure, basically they are quite older population. So yes, we can consider using technology, but do bear in mind that human interaction is still very, very important for this group of patients. Okay, we cannot just solely rely on the technology. We still need to actually really interact with the patients and to empower the patients, to educate the patients. Okay, thanks again for Jiang Ying. Okay, now I will invite our last but not least, okay, Ms. Juvena. Juvena, as I said, actually, Juvena is a very experienced cardiac APN. Juvena is going to share with us her experiences as an APN to take care of patients with heart failure. Okay, over to you, Juvena. Thank you.
Hi, good morning, everybody. My name is Juvena, the advanced practice nurse from National University Hospital. Hi, thanks, Prof, for the introduction and also for her invite to share my role as an APN in the management of heart failure. Before I move on to my role, I would like to share a case study. And this is usually the typical kind of heart failure patient that we see in clinical. Mr. A, a 45-year-old gentleman with past medical history of hypertension, diabetes. This is his second admission within 2 months for acute breathlessness with lower limb edema times 1 week. In his last admission, the transthoracic echogram that was done reveals an ejection fraction of 30%. For those who are unfamiliar, a normal ejection fraction, or EF, would be at least 60% above. We also note that his weight increased more than 4 kg since his last admission. So he was diagnosed with acute decompensated heart failure. Remember Mr. A, and we will come back to him shortly. Back to myself. You all may be interested to know what an advanced practice nurse is. According to the International Council of Nurses, the definition of advanced practice nurse is as follows. APN is an umbrella term that is given to a registered nurse who have acquired expert knowledge base, complex decision-making skill, clinical competency for extended practice. So an APN, what the APN can do is very much dependent on the country that they perform in. So for example, in United States, an advanced practice nurse do have prescriptive right, whereas in Singapore, not all APN have prescriptive rights. Lastly, a master degree is recommended for entry level. So in Singapore, a nurse who complete the master program will have to undergo at least 1 year of internship where coursework need to be fulfilled. At the end of the internship, they will need to go through exam where they have to pass and then become a full-fledged APN. So as I mentioned earlier, the characteristic of an APN is very much dependent on the country that they perform in. So in Singapore, we adopt the hybrid model, whereby 80% of the role will be the direct care provider. So whereby, the APN will be at bedside with the patient, performing health assessment, ordering, interpreting diagnostic tests, or as follows. The other 20% will be the professional leadership role, where the APN as a nurse do provide mentorship, teach the nurses or even junior doctor. Being the constant member of the team, the APN serves as a resource person. This is the overall scopes of practice that the APN perform, from direct care clinical role to the professional leadership role. APN as a collaborative prescriber, traditionally APN do not have prescriptive right, as I mentioned earlier. In 2018, there has been a legislation that has been passed, whereby APN and pharmacy, after completion of the national prescribing program, will be certified as collaborative prescriber, where they are able to order a list of medication. This provides opportunity for the APN and also to be able to perform more advanced role and expanded role. This in turn will increase our patient accessibility to healthcare. So back to the heart failure role that we adopt. So heart failure APN in NUH, we are part of the heart failure team, whereby the team is made up of consultant, registrar, and also the case manager. So what do we do? Daily, we will review all cardiac admission that is identified as high risk based on criteria. I will show you the criteria later. After picking up all this patient, we will then review all the patient, coming out with our plans, which then followed by rounding with the consultant to deliver the management plan, intervention. We act as the point of contact for this group of patients during the office hour. We take on referral from the rest of the team. And very importantly, we collaborate with the heart failure case manager and also respective allied health provider, such as the physiotherapy, MSW, to coordinate care for the patient. So these are the criteria that I mentioned earlier, whereby we will review the patient, the admission, and pick up patient that will be at high risk. Remember Mr. A? So he falls into the repeat admission within 3 months, not due to social reason. So APN as a direct care provider are as follow. So when we review a patient like Mr. A, first, of course, we assess them, do some history taking, perform physical examination, formulate diagnosis. We will then order and interpret investigation as relevant, review his medication, diuretics, or his heart failure medication to make adjustment if that's necessary. collaborate with other of the members, whereby if there's a need to refer to medical social worker, physiotherapists, and more importantly, we need to talk to the patient and family to find out the patient's insight of their condition and also their coping mechanism. The APN acts also as an educator, and this is a very big and important role that the APN has, because the patient needs to have a very good insight of their disease so that they are able to take charge of the disease, understand what is the disease process. So for example, they will need to understand what is the cause of heart failure. Is it due to hypertension? Is it due to post-myocardial infarction? By knowing how to take charge of their heart failure or even their condition, like for example, knowing the salt and fluid intake, knowing to take their own weight, it will then help the patient to keep them stabilized and also hopefully out of hospital. So using visual cues such as the heart failure action plan, this will give the patient an idea of, at which state they are, whether their symptoms according to their color zone, and what do they do and how are they going to respond to it. During the admission, the aim is definitely to discharge the patient. So discharge planning will start very early, even on the first day. Things like looking at the patient as identifying social and financial issue, so that we can have an early referral to the medical social worker team or any of the resources that can be in place. We will need to ensure medication supply is adequate to the next appointment. So our heart failure patient will usually be able to get early review appointment within 2 weeks. So we need to ensure that the medication is adequate so that the patient do not come in within them. Of course, to obtain heart failure clinic appointment. And we also provide remote monitoring service such as the teleweight monitoring service and transitional care such as Care Hub, whereby community service can be adopted. So this is an overview of the teleweight monitoring, whereby patient will be recruited, be it inpatient or outpatient. Then we'll teach them how to use the weighing machine, at which time point, okay? And then the weight will be transmitted over via cloud platform, where the APNs at the end will be reviewing their weights to see how are they doing. And if necessary, we will then have to give them a call, checking on how are they and making adjustment. So back to Mr. A. During his inpatient stay, we have to intensify his diuretic therapy, whereby IV Lasix was increased to 40 VD twice a day. Subsequently, when he achieved adequate fluid clearance, we will then discharge and to him to oral medication. We also need to find out what is the reason for his admission this time round. So we realized, and upon the history taking, we note that his non-compliance to his medication. So he claims that he does not know or he forgot that he needs to take his medication and what is the importance of controlling his fluid. Apart from this, we also may need to understand, is there any cognitive issue like what Prof. Catherine have mentioned in this group of patients? So for the outpatient, we also enroll him to the teleweight monitoring for 1 month and follow him up at the heart failure discharge clinic within 2 weeks. So these are my colleagues, cardiac APN in NUH. Okay, so a part of us, a few of us are the heart failure APNs. And lastly, I would like to thank my heart failure team that consists of the doctors, pharmacists, case manager, who is working together to keep the patient hopefully out of the hospital. With this, I end my sharing. Thank you very much.
Thank you, Juvena, for your sharing. Okay, I think just now Juvena mentioned about the MN program, Master of Nursing program. In fact, actually, this program is provided by our nursing department. So we are actually only the nursing school to offer this MN program to train our APN. Okay, also just a very quick summary of Juvena's presentation. As we can see, advanced practitioners actually plays a vital role in the management of heart failure patients. And the role is actually holistic and multifaceted, which combines inpatient, outpatient, and also community patient care skills. So I'm sure, I think for those, some of the local students, maybe in the future, you will also be an APN. So we hope that, you can come back to our school to study in our master program, and also you will be the future of our nursing profession, especially play a very important role in patient care. Okay. I think with this, we will end the session of the presentation, and now we move to the Q&A session. Okay, let me look at the Q&A, the questions posted by the audience. Actually, we have a number of questions for each of the speakers. So maybe my first question goes to Catherine. I think we have one question to ask, Catherine, do you think that correlation between cognitive impairment and heart failure contributes to poor management of heart failure? For example, non-compliance to fluid restriction. How can nursing care help such patients?
Yes, thank you very much, Wenru. Excellent question. I think it's spot on, right? I mean, just now when Juvena talked about the case, Mr. A, he's exactly had the problem, right? That poor self-care. He claimed he forgot and all that. So it's definitely, there is a link between cognitive impairment and heart failure in terms of self-care management. And a lot of our patients actually do tell us that they forget, they got confused, and then they mixed up the instruction. So how do we help these patients? Like what Juvena said, of course they do need to assess and they need to screen the participants, the patients, whether there's a cognitive issues. We recommended cutoff, like, brief tests like mini mental state examination and Montreal cognitive assessment is actually different from the standard, different from the conventional cutoff. Like, MSc less than 24 is not going to serve the purpose. By comparison, I would say it should be, higher. So that means it can pick up more. If you're higher, then total score is 30, right? So the higher score can pick up more. So we don't want to miss out those patients that they actually maybe, above 24, but then they actually have cognitive impairment. So we use the right cutoff point to pick up, to screen, to pick up. And then if these patients still have some, after you screen and they have issues, right? you may refer them for like formal diagnostic workup of their, do a formal neuropsychological assessment, or even all those, scans, whatever, just to check, whether there's any organic problem in the brain. In terms of nursing side, I think we need to then inform the patient, if they continue to forget, and there are some things to help them. For example, some apps can help them to remind, like, Dr. Jiang Ying's, presentation, the app, it will be useful in some way to remind them for the medication, for the, time to rest, take their fluid intake, as well as, I think involve family is quite important. I think, APN, they should also bring the family to educate the family, as well as tell them that it's important to repeat, write it down somewhere as a reminder. All these are compensatory strategies. Of course, hopefully our brain training, like Train Your Brain Heart Failure, can teach some memory skills for patients, so they can apply directly. So these are all under development. So I think we are confident that we can do more for our patient. We should customize nursing care for patients with cognitive impairment. This is really an untapped field. We need all the nursing colleagues' help and effort to make it helpful for our patient, to benefit our patient, because I think it's neglected in this area. Thank you very much.
Yeah. Catherine, you mentioned about the Train Your Brain. I think this second question actually asks about, is the Train Your Brain program possible to expand to other population with other chronic illness who are suffering from CI as well?
Yeah, thank you. Yes, that is true. Those patients with other cognitive impairment, for example, patients with diabetes, who is actually you know, they are also quite high, and they do have high cognitive, highly prevalent cognitive impairment as well in this population. And other patients, for example, stroke, definitely. And you know, for us, when we did the Train Your Brain program, we did it with all the older population, like 16 and above, but we actually realized even for heart failure patients, it's very prevalent. And then diabetes patients in our clinical service, we also found they are quite high as well, actually. Like, you know, it's almost half as well. Stroke patient we did study before is also, you know, more than half. So I think all this really can be customized. So what we do is actually we customize into population. Like now with the Train Your Brain generic program, we modify to Train Your Brain heart failure, and we can also do Train Your Brain diabetes with a specific disease characteristic and their self-care needs. So for example, the heart failure patients, you know, you do have all those, monitoring in terms of their weight, fluid, sodium intake, as well as medication. And for diabetes patient might be the insulin monitoring and things like that. So all that I think can be modified, can be customized. I think nursing care can be most effective. We actually make it very personalized, individualized, and customized. So I think that's what we are moving towards, and we need all the colleagues' support to make it this possible for our patient. Thank you.
Thank you, Catherine. Okay, because of the time constraint, I have to move the next question to our next speaker. The next question goes to Jiang Ying. Okay, Jiang Ying, I think Wenru asked, Dr. Jiang Ying, in your study, how was the IT literacy of participants ensured for the usage of mobile application as they are elderly participants? And also, are there any evaluation of costs involved when using the mobile app?
Oh, hello. Hey, yeah. Hey, Ronan. Thank you for the questions. Yeah. So in our particular study, we did have some screening to enroll our participants. So patients need to have a mobile app, and they will need to have like internet access at home and like outside. So and they need to use the smartphone. That means on a daily basis. So we look at them how to like operate their phone, a simple usage. Because our heart failure app, when we decide, we also decide as the like elderly friendly kind of app. So we don't decide a app that's a very complicated. But having said that, we still need to. So we have some screening like criteria to see whether they are able to use the smartphone in daily usage. So yeah, this is our inclusion, screening eligibility criteria. So there are some, I didn't report here, but we did because of this, actually some of the patients, they cannot meet our study inclusion exclusion criteria. That's why the recruitment rate is only like 30%. So this is one of the barrier as well. Yeah. As for the cost for the study, for this study we didn't have a cost evaluation. But moving forward, this is a very good question. I think we need to look at the cost cost-effective perspective. So this could be one of the outcome criteria in the future study. Yeah.
Yeah, maybe to add on. Maybe just to add on Jiang Ying's answer. So actually, when we developed this app and the whole system, we try to involve the user, the patient, and also the clinical team at the very initial stage. We make it more user-friendly. And also actually for the app, it's not only actually just for the patient, we also teach the family members or maybe their caregiver. They can actually help the patients to monitor their data and use the app. Because we know that for this group of patients, they are generally very old. So I think for most of the older patients, it seems that they still prefer paper document, but we try to involve the families and also the helpers to help the patients to use the app. And also, I think if you listen to Jiang Ying's presentation, so at the end, so basically experimental A and experimental B, there was no significant difference, except the unplanned health service use, in terms of the hospital readmission and also the emergency room visit. So those group of patients who use the app, they actually have reported significantly low numbers of hospital readmission and also emergency room visit when compared to the control group. Whereas for the experimental A, so those patients in the experimental A, basically they actually don't use the app. So there is no significant difference in terms of the unplanned health service use. So this may also indicate that this technology may help actually us to reduce the unplanned health service use. Although we didn't actually do the proper cost effectiveness analysis for this study, but we did actually we did a variation on the unplanned health service use. Somehow that we can actually indirectly reflect the cost effectiveness of the intervention. Okay, I hope that Rona, I answer your question. Okay, yeah, maybe move to the next one. The next question. Yes, again for Jiang Ying, sorry. And I would like to know. So this from Shirley. Shirley asks, I would like to know how do you define the reassessment time point of your study? Any evidence from your systematic review?
Hi, hello, Sharon. Thank you for the question. Yes, actually, we did some of the systematic review before we decide our study intervention and follow up. So basically, from the systematic review, normally the most of the study follow they varies. So from 3 months, 6 months to up to 12 months. Majority up to 6 months. So this is taken into consideration for the evidence in the literature as well as some of the pragmatic concerns. So we have some timeline for the conduct the study and all this. So we set as 6 months.
Okay, I see there are still some questions for Jiang Ying. I think I need to give some time to Jocelyn and also Juvena. So so I'm sorry that due to the time constraint, we are not able to answer all your questions, but you can actually find out her email in our school website. You can always approach Jiang Ying and me, okay? So I think we have one more question for Jocelyn. Jocelyn, I think this question is asked, were there any significant changes in biological markers post-intervention? What are your speculations for that?
Thanks very much for that question. I think this is a question that all of our projects would very much want to answer. So regarding the biological markers, actually we did not find any significant differences between the groups at 3 months and 6 months. And one of the speculation, we actually have two speculations. One of them is that it's possible that the participants have actually gone for their regular medical checkup on things like that, and hence medical therapy could have been already optimized. And so, based on their drug, maybe they could have increased their diuretics or beta blockers such that their biological markers have actually improved or not decreased for that matter. So that's one speculation. Another speculation could be because of a ceiling effect. Maybe it has already reached the maximum that they could improve. Because heart failure, we know that it's a chronic disease with a decreasing trajectory, decreasing trend in terms of illness trajectory. So which is why in the last slide of my presentation, I actually also mentioned that it's important for us to start self-regulation programs earlier. I'm coming from a preventive health perspective. So once participants have, you've identified the participants who have CAD, maybe even hypertension or diabetes, then maybe you should already start the self-regulation program so that you can delay the disease trajectory and disease progression. So that's my answer. Thank you very much for the question.
Yeah, I have one more question for you, Jocelyn. I'm sorry, okay. And there is one question to ask, behavior change is difficult and relapse actually is common. We know that, right? So then how we can sustain self-regulation and behavior change beyond the interventional period?
Thank you for that question, and that is a perfect question, and it's something that everyone, I think every behavioral scientist would want to solve. Regarding behavior change, yes, it is difficult even for myself. So I think the first step we could take is to really sustain at a certain behavioral goal such that it becomes a habit. So once it becomes a habit, then it comes automatically. You don't even have to think about it. You are doing the right thing. So while you are creating that habit, be it 21 to 66 days, you have to constantly monitor yourself. And at the same time, like everyone has mentioned, you need your support from family, from healthcare professionals and things like that to constantly give you the coaching and the motivation that you need. Of course, peer support is also very important. You need your friends to bug you in. Like I mentioned my personal story just now that, my colleagues have been texting me every night that, hey, have you gone for a run? And then send me a picture of them running. And then I feel guilty for not running. And then I immediately, wear my exercise clothes and go out and at least walk a bit. So things like that can actually help you build a habit. So the point is, you have to build habit through constant repetition of the same behavior such that it sticks in your mind. Like, we've talked about cognitive function just now. Prof. Catherine Dong has also mentioned. So building a behavior change, you require a change in habit.
Yeah, thank you, Jocelyn. Okay, I think here we have another question. Maybe I will refer this question to Juvena. Juvena, there is one, I think Mr. Chen or Miss Chen. Actually, this audience asks, with the experience of COVID-19, I would like to ask the speakers whether the chronic heart failure management can or will be changed into online or e-health model. And would e-health be the future direction of the development of management of chronic illness in Singapore or worldwide? So maybe Juvena can probably answer, like specifically for patient management of patient with heart failure. I think you mentioned about the, telemedicine that we have been put in place, in the hospital. I probably can also add on a bit of the answer. Okay, thanks, Juvena.
Yes, thank you for the question. So I think, COVID-19 have put us to a very new norm. And like Jiang Ying mentioned about the apps and the remote monitoring that we are providing, that will act as a technology base whereby moving care to technology. And in fact, right, if you were to know, there is a lot of medicine or consultation that is upcoming, which even before COVID-19, this can be done somehow or rather, because COVID-19 set in place and a lot of things, even like our webinar, this is put on virtual. So yes, the question about whether the care of chronic diseases can be as a telemedicine, telemonitoring, or even whether technology can come in place, I would think that is a possibility. So something to explore on. And
to add on Juvena's answer, I think yes, I think the answer is yes. That there is this is actually the future direction with all this advanced technology. You cannot just plug your eyes and see, okay, we just do our traditional kind of care. We do home visit. So using technology, to help us to enhance patient care is very, very important. That's definitely the future direction. And actually, I myself have another project for patients with DM. Diabetes. When I start the project, actually at the time, the COVID-19 haven't started yet. So, but I already actually tried to do this study in the hospital. But during the COVID-19, this system really, really helps the patients. So that particular project is actually targeting for patients with poor glycemic control. So during the COVID-19, we try to ask the patient not coming back to the clinic to do their follow-up. So what we did, actually, we use this whole system. We also developed an app and also the web portal. So the nurse actually can really monitor patients' blood glucose remotely. So the patient don't really need to come back to the hospital to do their follow-up. So they actually really use the system to help the patients. But again, as I said, when we use the technology, we need to be careful and especially for older patients. So for older patients, as Jiang Ying mentioned that, human interaction is still essential. So most of the older patients, they still actually prefer the healthcare professionals or the nurses come down to their home actually to see them. Okay, you cannot just actually purely rely on the technology, especially for those older patients. Okay, Yes, I think, I think we still have some questions. I'm sorry that we can not answer all your questions, but again, you can always approach us through our emails. So we are also happy that, you know, in the future we can do some, you know, research collaborations. I think all the speakers actually put up their email address. I hope that you have really take note of their email. Anyway, you can also find their emails from our school website, okay? Yeah, so with this, I think we will end the session, but now I think our chat function has opened. I hope that you can leave your comments, your feedback, you know, to us so that we can further enhance our webinar. Thank you very much. Thanks for your time.
All up in my head, fear's got a hold of me. Pretend I'm not scared of who you call